Muted.
Welcome everyone to today's webinar. I'm Josh Johnson, Care Management Consultant with Novia Strategies. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer section. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. Today's webinar is titled A New Day in Healthcare, the Need for New Approaches to Care Management. We will learn how a leading healthcare system is transforming their care management model to ensure they are well positioned for the changes in healthcare reimbursement. Located in Tuscaloosa, Alabama, DCH Health System is a public, not-for-profit hospital system owned by the citizens of the community. For more than 90 years, DCH has been providing high-quality and compassionate healthcare to its community in West Alabama. Today, the system includes DCH Regional Medical Center, Northport Medical Center, and Fayette Medical Center. These facilities are owned by the public, and the system is operated on behalf of the public by the DCH Health System Board of Directors. At this time, it is now my pleasure to start today's webinar by introducing our speakers. We have two wonderful panelists with us today. Carolyn Hamilton holds the title of Corporate Director of Care Coordination for DCH Health System. She is responsible for providing oversight and leadership to acute care management teams across the system. Her passion for quality health care has served her inspiration for more than 30 years. Carolyn received her undergraduate degree in nursing and Master of Science in Management from Indiana Wesleyan University. She holds certifications as a case manager, clinical documentation specialist, and professional in healthcare quality. Donna Hopkins holds the title of Vice President for Novia Strategies and plays a leading role in the firm's care management transformation practice. She has led the DCH project over the past 2 years and continues to partner closely with Carolyn and her team to transform their care management. Donna holds a Master of Science in Nursing from the University of Texas Medical Branch Graduate School of Nursing. She is also a member of the American Case Management Association and the Case Management Society of America. I will now turn the floor over to Donna.
Thank you, Josh. I'd like to begin our discussion today by establishing the context for this new day in healthcare. Cost avoidance has always been essential to the work of acute utilization management departments since the inception of the DRG system. Utilization review for Medicare and contracted payers and focusing on length of stay vulnerabilities were original primary objectives. Resource management and discharge planning were later added functional expectations as acute case management practice came to be. I have always used the analogy that we took the disparate roles of UR, discharge planner, and social worker and hit the Make It Fit button to call the combined functions case management. In 1997, the Balanced Budget Act introduced the post-acute care continuum and the prospective payment system to those venues. Discharge planning and triaging patients to a next level of care took on greater emphasis within care management and has driven post-acute care use in order to keep acute care length of stay down. In the late 90s, the Triple Aim furthered the need for organizations to begin looking at the cost of care. Still, in most case management departments, in spite of the need to focus on care progression and eliminate waste, length of stay and discharge planning continue to be the primary functions. Healthcare organizations are now moving from volume to value-based care, and we see that over 50% of Medicare reimbursement models are expected to shift to alternative payment models by 2018. This means that hospital margins are threatened as never before, and care management must change along with it. Medicare spending per beneficiary, MSPB, part of the IMPACT Act, is a relatively new CMS regulation shifting providers from volume to value. This new metric spans the healthcare continuum and further drives the need for cost reduction and clinical redesign across the full continuum of care, from pre-hospitalization into the acute care environment and after discharge into post-acute. With MSPB, it is widely acknowledged that controlling use of the post-acute continuum is essential, and care management staff are again noted to be the influencers to improvements of its use. MSPB and reducing the cost of care have triggered a new day in care management practice. Let's take a look at how one organization is preparing their system, and specifically their care management model and staff, for the need to change. Carolyn, you recently assumed a corporate director position at DCH and joined a year-long journey in a broad care management transformation project. I have heard you speak of the accelerating burning platform for change. Tell us that story.
Thank you, Donna, and I'm thrilled to share our journey. As you and I have discussed many times, there is a hurricane of change blowing through our healthcare culture that is fundamentally changing how we work, collaborate, refer, relate to our patients, customers, each other, and the world around us. I'd like to share a story with you, and it's one that really has stuck with me over the years. The Choluteca Bridge is a suspension bridge in Honduras. It was built in 1938 by the United States Army Corps of Engineers using U.S. and Honduran capital. This expansion bridge spanned the Choluteca River, and at the time it was built, the bridge was really considered to be one of the greatest works of architecture in the country. Then Hurricane Mitch hit Honduras. When Hurricane Mitch came through, it wiped out 150 bridges and much of the infrastructure of Honduras, but not the Choluteca Bridge. It still stands. But there's one thing the bridge can no longer do. It can no longer get you across the river. No, this bridge experienced something else entirely. The Choluteca River still flowed, but with 75 inches of rain in 4 days, it carved a new path about 100 yards to the right, leaving the bridge useless for crossing the river. Still a great-looking bridge. It's strong, it's well built, has a solid foundation, but it just doesn't function as a bridge anymore. The river did something unexpected in the face of overwhelming force. It didn't flood, it didn't dry up like we would expect, it just moved. So our culture here at DCH, like the Choluteca River, is shifting. Healthcare is going in a direction that we did not anticipate or prepare for. For example, at DCH, we were not prepared for being selected as part of the mandated joint replacement program, the bundled payment for total joint replacement. If we don't embrace this shift with its new paradigm, we're going to end up like that bridge, standing isolated, disconnected, and useless on a levee while the river flows by. We need to rethink how we're doing our work to connect with patients, families, and providers. Are we a bridge upon which they can cross safely and successfully to the next level of care, or are they falling through the cracks?
I love that story, Carolyn, and its analogy to what's happening in healthcare today. And you're so right. Healthcare is shifting in ways we never anticipated, and we do need to cultivate new approaches to care management. For me, Medicare spending per beneficiary has been one of the signs that indicate a need to a new approach. This CMS initiative and bundle payments impact all Medicare beneficiaries across entire episodes and are forcing us to move from length of stay to cost of care. Carolyn, in addition to the mandated total joint program and efforts that you mentioned a few minutes ago, what else has signaled the need for a new approach to care management in the acute setting?
Well, several things occurred for me which signaled the need for a new approach to the work of case management in the acute setting. It became apparent that the outcomes reflective of our work is increasing. Length of stay, case mix index, readmissions, and now MSPB all mean that cost of care has to become foremost in our work. I know that the main emphasis of Novia's work here in DCH was on infrastructure, length of stay, and clinical documentation workflow. And Donna, I was not here at that time, so would you describe the environment that Novia first encountered here at DCH?
Absolutely. When we were first invited to partner with DCH, we found that care management department was not exactly traditional in design. It had become predominantly focused on patient statusing, with more staff performing remote utilization review and remarkably less staff working at the bedside. Novia's aim was to realign infrastructure, implement an ED care management program, and reduce length of stay. We also were tasked with blowing up the silos internally within the department, as well as externally with nursing and other ancillaries. We were able to influence the organization to recognize the need for strong leadership in this area to continue to execute and sustain improvement. During most of our engagement, the metric of success was length of stay. However, the winds of change are now triggering the need for new metrics and changes in practice.
That's right. In care management, we have always had a stake in helping to reduce length of stay. Now, we must also address waste and reduce spending. As care management leaders, we need to help everyone see that they have a responsibility and an obligation to ensure that if patients are in beds in our hospital, that they actually need to be there. Not only is occupation in that bed incurring financial liability for the patient in the hospital, but it is also not without risk. It's actually a potentially dangerous place to be. We know that healthcare error is now known to be the third leading cause of death. So from a safety standpoint, we are doing the patient and the system a disservice when we allow patients to remain in the hospital when they can be managed at a lower level of care. Here at DCH, we are constantly asking, what are we doing that mom, dad, brother, sister cannot do? Being good stewards of patient and hospital resources has always been an obligation of care management, but it's taking on even greater significance today. The biggest problem, I think, is bracing for change in the actual transition from our rigid bridge to something that actually spans the river. First and foremost, we must acknowledge that the status quo is not good enough and admit that we can make an improvement. If we focus on doing what we've always done and currently do, it can blind us to the need to further adapt. Using that Choluteca River Bridge analogy again, the work before us as hospital leaders is to expand our current bridge across where the river is now by getting out ahead of readmissions, collaborating with the QIOs and external partners, and taking on care management practice, actually taking it outside the four walls of the hospital. As care managers, we're going to need to take ownership of the challenge and extend the bridge to better care coordination and transitions that are going to lead to improved outcomes.
Change is always difficult, especially the kind of organization-wide changes we're talking about. Carolyn, I know from our previous conversations that focusing on the cost of care has really helped you gain traction in implementing needed changes. Tell us how the need to address cost of care has helped you gain buy-in for the next changes at DCH.
Sure. Well, we have become, I have started discussing the importance of cost of care with the leadership and the management group, helping them see the importance of the cost of care and actually providing to the case management team and the leadership of the hospital the permission to discuss cost of care. In healthcare, we have had a tendency really to shy away from talking about the cost of care. In fact, over the years, I guess probably one of the most dreaded comments we hear about our work is, "You are just all about the money." Well, the fact is that we are not just about the money, but we do manage the revenue cycle for all acute inpatients and now for many post-acute patients. So we are about the money, and it is okay to admit that. We have actually expanded discussing the cost of care, not only with leadership, but with patients, families, physicians, external partners.
Another strategic change by your leadership has been to invigorate the role of the physician advisor. The physician advisors at DCH have become significant partners with care management and nursing as advocates in reducing overutilization and supporting administration's messaging. What else makes the physician advisor role at DCH different from what we see in most other acute care environments?
Well, as changes occur in healthcare, the role of the physician advisor is taking on even more importance. No longer a nice-to-have team member, the physician advisor is essential to hospital care management programs. We are fortunate to have an administrative team that recognizes this and supports us to have a very advanced and supportive team of PAs providing coverage 7 days a week. The work of our physician advisors has expanded and involves much more than status reviews. They serve as advocates for the care managers and as liaisons between the care management team and the attending or consulting physicians. Not only are they on site 7 days a week, but they also attend our rounds. Our physician advisors help to ensure that our hospitals are appropriately reimbursed for the care that we provide and that patients move smoothly through the continuum of care. This role has evolved in our system to support the delivery of high-quality patient outcomes, cost-effective care, and spot-on care management.
Thank you, Carolyn. I know your physician advisor roles aren't the only roles that have changed. We have also discussed the work by care managers also needs to change. Tell us about that.
Sure. For one thing, we're changing the way we craft the discharge plan by leaning toward the least restrictive environment. Why not home has become our mantra. Patients have the right to the least restrictive environment, and we must identify and determine as part of the discharge planning process the least restrictive environment appropriate for the patient to be discharged. So this increases the importance for us in our work of discharge planning to look for that least restrictive environment by better planning, to look for that, try to get them especially when out to the community, especially when there's a competent, willing, and able caregiver. Shifting post-acute care from more expensive services such as LTACs and skilled nursing facilities to less expensive services such as home health when it's medically appropriate, that can really help. But it's really a mindset that requires us to change the way we think about and facilitate the discharge process. We've also seen the need to narrow our post-acute network using data. I've met with the skilled nursing facilities in our community and provided them with the Medicare spending per beneficiary data and their own cost of care compared to others in the community. In other words, here's what it costs us to send a patient to you compared to the mean of sending it to others. This is really especially important for the joint replacement patients, but actually important for all Medicare patients in the world of MSPB. Hospitals can reduce penalties and improve their MSPB measure by reducing Medicare spending and fragmentation. We know that long gone are the days of making referrals to the agencies who bring us brownies, pens, and notepads. These sorts of friendships just no longer have a place. By examining the data, we found that oftentimes the highest cost nursing home is the one we are referring to the most frequently. While patients have a choice to choose their post-acute providers, and we do not hard steer our patients, the list we provide our patients no longer is just alphabetical by geographic location. We now weight our list by overall CMS star ratings, and revising the list isn't just to reduce Medicare spending. With this revised list, our patients are being discharged to skilled nursing facilities or agencies offering them the highest quality of care and upholds the mandates of the Triple Aim by providing the highest quality of care at the lowest cost. I've also taken all of the MSPB information to the Utilization Management Committee so that the entire committee becomes more comfortable discussing and looking at the cost of care.
I'm curious, Carolyn, with Medicare spending per beneficiary and the new mantra of why not home, do you anticipate that length of stay will increase?
Well, it just might. It is possible that the MSPB may increase the length of stay, Donna. The reason for this is keeping the patient another day or few days may assist us to avoid a whole nother post-acute level of care. So instead of a skilled nursing facility or an LTAC stay, the patient may be able to stay a few more days in the hospital and then return straight to home with home health care or with outpatient care. Now, this is going to require a mindset change for care managers as well as the C-suite, but it puts even more emphasis on getting the right care to the right patient at the right level of care.
I see the need for increased accountability among care management staff and managers. What are you doing to instill greater accountability in these roles?
Well, interventions and stoplight reports were two of our primary tactics that we're using to instill greater accountability. We started daily transitional rounds on each unit. Care management leadership follows up then on the barriers that are and what is needed to overcome those barriers of getting the patient to the next level of care. We hold a weekly multidisciplinary long-stay rounds meeting for patients with a length of stay between 7 and 15 days to assess barriers to discharge. In addition, we hold a weekly small accountability group for the manager, case manager, and social worker, and myself to ascertain the barriers and identify strategies to overcome those. We all hold quarterly one-to-one purposeful rounding with our staff members, and we're asking each one of those meetings, we're asking what's going well, what's going not so well, do you have the tools and equipment you need to do your job, and is there anyone I need to recognize for you? We also use a stoplight report that we post quarterly, and it really just includes the things that from our rounds our teams have suggested. Red is for the things we cannot do and why. Yellow is for the things that we currently are working on or are budgeted for, and green is for the things that have been accomplished as a result of their feedback.
You mentioned rounds, Carolyn. I know capacity rounds were initiated over a year ago in one of the ICUs there to address patient throughput challenges. How has that effort been extended?
Well, we expanded those rounds from 3 times a week to daily. On any given day, it was not unusual for us to have at least 1 or 2 patients waiting in the ED on a ventilator, waiting for an ICU bed. So we knew that we had to increase that. These walking multidisciplinary rounds include representatives of the various departments included in patient care, the nurse manager, staff nurses, pharmacists, social worker, case manager, respiratory therapist, and a physician advisor. Our physician advisors are very active on these teams, and they will pick up the phone right during the round, in other transition rounds as well, to facilitate patient movement. In the ICUs, we discuss patients' continued appropriateness for the intensive care level. Patients who no longer meet the intensive 1-to-1 or 1-to-2 level of care are identified as ready for transfer to a step-down or a medical surgical level of care. Potential issues around the transfers are also being addressed during rounds. Every day, patients appropriate for transfer are identified, and diversion has occurred at only one time in ICU since those rounds, the capacity rounds, have started, and that was just for 4 hours on a Saturday. These ICU rounds have recently also been extended to a second 16-bed intensive care unit with similar results, and we're now extending them to the weekends. Yet another tactic that we're using to drive accountability is that we revised our performance goals and reviews. We added that accountability piece for some of the most important areas of performance for our care management staff, such as scheduling and critical thinking skills, with the full expectation of a Plan A and Plan B. A reactive approach has been replaced with a more proactive approach to the work of care management. Staff are being held accountable for coordinating the complex processes of care for today's acute care patient. Our care managers need to be professional, active participants in the management and direction of patient care, no longer blindly following physician orders, but going the extra mile to make sure that the hospital will be paid for the services we provide and the patient is at the appropriate level of care. The case manager role is no longer just a role for lightweights or tired nurses who would like a soft place to land prior to retirement. Care managers need to be assertive, proactive team members and expert in care coordination, engaging the patient at the same time. Care management, we recognize it and promote it to be, it is its own specialty area with a professional designation, skill set, and body of knowledge. We just cannot simply punch in, punch out, and make it through the middle.
Carolyn, as we both know, data is key to assuring accountable care management practice. What data do you monitor for needed actions on a regular basis?
Well, as you can see from this slide, we have weekly, monthly scorecards for care management physicians and nursing. These scorecards are in use to assist the analysis of current performance and areas in need of improvement. We're also rolling out the individual nursing units length of stay, case mix index, and excess days data to increase accountability of metrics at the unit level. The nurse managers at DCH are being held accountable for these metrics as well. And the care management, we know that care management departments alone cannot solely control metrics like readmissions, length of stay, cost per case, throughput, but we can certainly impact and influence these metrics and assist the entire culture to be a proactive, shared sense of urgency to deliver high quality, cost-effective care across the continuum.
How true that it extends beyond just care management. Carolyn, you and your team at DCH are truly achieving wonderful outcomes as care management continues to transform there. And clearly that journey isn't finished. I'm sure our listeners today would love to hear what you are working on next.
Thank you, Donna. Yes, our journey is ongoing for sure. In fact, one of our most recent undertakings has been to join with our Medicare Quality Improvement Organization to form a coalition that includes more than 50 area healthcare organizations in 6 counties to help reduce readmissions. Hospitals have been charged with reducing readmissions for quite a while, but it is great that right now CMS is finally realizing that hospitals really cannot do it alone. It will take a team of community providers all working together to improve care transitions to the point where it actually reduces hospital 30-day readmission rates. This has been just really a very exciting opportunity to bring our external providers along with the other hospitals in the area to actually improve access to care.
That's a wonderful opportunity, Carolyn, and I can't wait to hear more about it as the initiative progresses. As we move from our work in the acute environment and evolve into responsibility of the post-acute space, this can be an immense undertaking for acute care organizations who've always focused on turning beds, and especially when the post-acute providers are not within your system. Some hard questions we're hearing from our clients are, how do you prepare your CFO that you need additional staff outside the box? And how will you work to reduce the redundancy of work among the plethora of roles and disciplines performing transitions of care work? I know you are incorporating the role of navigators at DCH. We are seeing the navigator role as still evolving, but as the point person for the patient and family and multiple providers and spanning a longer episode, or in a role that will require not only negotiation and coordination skills, but the ability to address disease states, medication and appointment adherence, and other needs not commonly addressed by acute staff.
That's right, Donna. Of course, the acute care management staff will continue to have the ultimate responsibility for a safe plan, as always. But the navigator roles will work with the patient, family, surgeon, primary care physician, care management staff, and post-acute facilities and agencies, all to help make the patient the center of the universe. We have just hired our first navigator to work with patients and families prior to admission and post-discharge for 30 to 90 days. This is the first time that we are actually taking our care management outside the 4 walls of the hospital. As a hospital operating in a comprehensive joint replacement program, we have recognized that we cannot just leave that 90-day post-joint replacement to chance, and this is only the beginning. In this world of bundled payments, care navigators, we feel, are going to be needed to help weld the silos of care both inside and outside the hospital. We recognize that the care management navigator is going to be essential to ensure that patients are optimized for surgery, receive appropriate discharge planning to that least restrictive environment, transition from one level of care to the next in a timely manner, and of course are followed for 30 to 90 days to help prevent readmissions.
Carolyn, as we wind down our conversation today, do you have any thoughts or lessons learned for our audience?
I do have one more thought that I'd like to share yet. I think we will need to recognize that the current regulatory environment is here to stay. These are complex matters, all aimed at inpatient hospital owning or guiding patients through the entire episode of care. And whether we like it or not, we as case managers, care managers, the leadership of care management are thrust into the entire care continuum for our patients. We will need to ensure that we are utilizing all available resources, and we will need to become experts at removing barriers to affordable and cost-effective care. We will be moving into a far broader scope than merely focusing on inpatient services. What happens before patients ever arrive, when our patients leave the hospital will impact not only the patient, the hospital, its viability, and all other providers as well. And this ultimately will improve quality of care, which is what we all want to do.
Thank you for sharing your organization's journey. Certainly the changes needed begin with the vision and abilities of a strong leader like you to not only educate other leaders and peers, but to execute operational tactics to hardwire the changes. My question to the audience is this: what is your call to action as a result of the discussion we've had here today?
Thank you, Carolyn and Donna, for that fantastic discussion. We're now going to open the floor to the audience and any questions they might have for us. As a reminder, you can submit any questions you have for our speakers by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We will try to get through as many questions as we have time for. Carolyn, the first question we have is directed to you. The question is, you've shared how care managers' functions will be affected by the changes, but how will other disciplines such as nursing, social workers, therapists, or even pharmacists be affected?
Well, that's a great question, Josh. And really, it's one that, we have started rolling out. As I said, we're rolling out the scorecards to the nursing units and the nursing managers, the nurses on the floors. Each unit are going to be held accountable, and they're being held accountable for those numbers. But we're also adding ancillary staff to our UMC, to our Utilization Management Committee. Utilization of resource monitoring is going to include outpatient and ancillary departments as well as inpatient. Departments that we have found to have a lot of avoidable days or opportunities for improvement are now being added to our Utilization Management Committee, and they will be able to report and kind of receive assistance from that whole multidisciplinary team, a perspective to try to overcome some of those barriers. Some of those that we've added are going to be radiology, cardiovascular, cath lab, the laboratory, therapies, pharmacy.
Okay, great. As a bit of a follow-up question, Carolyn, can you talk a little bit about how your case managers are aligned, and specifically, are they geographically assigned or assigned by provider?
We are a triad model, a full-blown triad, and we are actually, we would love to have our case managers assigned by physician, because we all know that that is really the best model with the best outcomes. However, because we are a large academic medical center, regional, is that we have so many units that we really are not able to do that. So we assign our case managers geographically, but that ends up being, a lot of that ends up having them on with the same physicians.
Okay, thank you. Donna, would you please elaborate on some of the more specific changes that will be needed in care management's day-to-day practice?
Well, I think in day-to-day practice, we're going to need to see more partnering, seamless, patient-focused work that we do. The partnerships that we have, not only with other disciplines, but within our department, between the RN care manager role and the social worker, is key. Visibility is also key. I remember a time when care managers were in the basement and maybe not as exposed, if you will, out on the unit and as visible as I think they need to be. Something else I think that might need to change in day-to-day work in the care management world is how we introduce ourselves, and to introduce whatever episode that definition is, that we're navigators and we're helping patients and families navigate our very complex healthcare system. And the last thing I want to say is that this role is no longer, in our day-to-day work, it's no longer just about the discharge, any more than it's all about the discharge, like the money. Yeah, we are about the discharge, but we're about much more than that, and we're connecting the dots for patients and families every day.
That's a great point, Donna, and actually leads us into our next question, which I'll direct to you, Carolyn. What is the most common function overlooked by case managers that can have a significant impact on the progression of patient care?
That's a good question too, Josh. I believe probably in that area, it would lie with the identification, just a simple identification of barriers every single day. What is keeping this patient in the hospital today? Remember, what are we doing that mom, dad, brother, sister cannot do? What is the barrier today to moving that person to the next level of care? What can I do as a case manager to overcome that barrier, to jump that hurdle, knock down that barrier? Is it IV antibiotics? Are we going to watch the labs? Can any of that be done in a less acute setting? What's keeping that from occurring? So I think ultimately it's identifying the barriers and have that mindset that I come up against a barrier, but it's up to me to find the answer to it. And I think that is probably the most common function that's overlooked, that's we get all caught up in all the tasks associated with what we do, but what is the barrier today and what can I do to overcome it?
Great. I'll actually direct this question to both you. First you, Carolyn, and then Donna, if you could weigh in as well. The question is, have you had any physicians who were resistant to change? And if so, how have you addressed these issues? Carolyn?
Well, yes, we do sometimes have physicians who are resistant to change. In fact, I don't really know a physician who is not resistant to change, but we have some physicians who have been especially resistant. However, we see those barriers being broken down every single day. As we are working with our physicians, we're providing them data, and we are helping them to see with MACRA coming again about how physicians are going to be paid for their services. It's going to behoove them to work with us, helping them understand that we are just here to help their patient, and focusing on that has been very, very instrumental in helping us have doctors who are now starting to look for us, before they even would think about going out on the floor. They're going to find that case manager to talk about their case.
I'll add a few things, Josh, if I might. I think certainly we know data rules, and showing medical staff their data is, and risk-adjusted data to boot, really does help to bring some resistors along. I believe we like to focus on those early adopters, if you will, and work with them and reward and acknowledge them. Another thing we found very positive at DCH was the role of the physician advisor again. I guess grooming that role and helping those men, they're wonderful out there, sometimes not having the first conversation, but certainly having the follow-up conversation. And because they, quote, acknowledge not having skin in the game, they've been very effective at getting even some of the later adopters to change at DCH.
Thank you. Carolyn, how can the work done by case managers positively impact the patient satisfaction scores?
Well, the key, I guess the key probably, there's one question on that HCAHPS survey that addresses patient satisfaction where case management probably has the most skin in the game. And that question is, during this hospital stay, did doctors, nurses, or other hospital staff talk to you about whether you would have the help you needed when you left the hospital? And that one is the one that really has, like I say, we have a lot of skin in the game on that one. It's typically an HCAHPS question, by the way, that scores very high across the country. So we encourage our team to let patients and families know with sort of a scripted encounter. With almost every encounter that they have with patients or families, we encourage them to say, we want to ensure that you have the help you need when you leave the hospital. And, having people to hear that, we feel is has been very effective in helping us to get scored well in that area.
Great. We've got one final question. Don, I'll ask you to weigh in first, but Carolyn, please weigh in as well. What challenges do you see hospitals and systems facing as they try to improve their care management process across the organization?
You know, Josh, we recently heard one COO acknowledge that he knew that the changes that were needed were going to be hard, but that he had no idea of the complexity that the changes occurring would impact so many other roles and functions in the organization. Truly a systems theory impact, you might say. You know, you can't change one element without the rest of the system needing to also change. That's hard work. An example of this is the effort it takes to bring care coordination, and I bracket those words, back into the co-joined work of care management staff and nursing and others on the team. Moving from a task orientation by all roles and evolving to better communication, coordinating care delivery, and keeping the patient as the center of that coordination is often a huge unlearning in day-to-day practice. We have found that at the elbow coaching and mentoring of care management staff and even managers and PAs is key to assure that follow-up and true care coordination is occurring.
Yeah, that was all. Yeah, that was all great. I couldn't agree more with that. Another thing is just the importance of how integral to a hospital system case management is. A lot of times case managers themselves don't even recognize how important it is. And that's one of the things as case management leaders I feel like we can do. We can really help our leadership, our C-suite, recognize the importance of case managers. Helping case managers recognize how important they are to the system can go a long way. That navigator position, taking case management outside the walls of the hospital, is going to be key as we move forward, I believe.
Don't you think, Carolyn, one more thing, Josh, I want to add, is that having that one single leader and the vision of the single leader over those multiple roles, you know, and assuring and aligning the vision, you know, your vision along with all the directions of all the different staff is also essential, don't you think?
Absolutely, and we have just started doing that. We have just put out a little 3 or 4 slide PowerPoint that we begin each and every case management meeting with. Anytime case managers come together, we meet with this. It's our hospital mission, and then it's our where our mission of case management, how it feeds into the larger mission, and then it's that one HCAP question, which is during this hospital stay, the doctors, nurses, everyone talk to you about the help you would need when you left the hospital, so that we can try to just really focus and see how we fit into the whole bigger model.
Excellent. Wonderful. Thank you so much, Donna and Carolyn. And I'd also like to thank the audience for your participation today. This concludes the end of our presentation. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.